Hi everybody, welcome to our module on cerebral and lacunar strokes. So before we get into specific type of strokes, let's just review the etiology of strokes in general. So the majority of strokes, about 80%, are what we call ischemic. This means there's insufficient blood flow to a portion of the brain. And this can occur from thrombosis, if you have a blood clot in a blood vessel. This can occur from embolism, so if you have a blood clot in the heart or the carotid artery that travels to the brain, that can cause ischemia. And it can occur from systemic hypoperfusion. So, for example, a patient in cardiogenic shock can underperfuse their brain and cause ischemia. And the symptoms in ischemic stroke, especially for board exam questions, are usually onset over hours, so they tend to come on more slowly. Hemorrhagic strokes, on the other hand, are when you have bleeding into the brain. These are less common, and these tend to have sudden onset, especially in board questions. And the best first test is always a non-contrast CT of the head, because this will let you know if there is bleeding present. So this is a picture of the vertebro-basilar system of blood vessels and also the circle of Willis. And there are three major vessels that supply most of the blood to the cerebral cortex. One is called the middle cerebral artery, the other is the anterior cerebral artery, and finally the posterior cerebral artery. So if we look at this picture over here on the left, first we have down here in the middle the posterior cerebral artery, which I'm circling right now. Then if we go up to the top, we can see the anterior cerebral artery. It comes off right here and goes towards the anterior portion of the cortex. And then over on the side, we have the middle cerebral artery right here. So those are the three main sources of blood to the cortex of the brain. For your board exams, you're going to need to be able to identify patients who have MCA stroke syndromes and ACA stroke syndromes and PCA stroke syndromes. And to do that, you need to know the portions of the brain supplied by each vessel. So let's take a look at this picture over here on the right. We're going to start with the PCA because that's the easiest to understand. This yellow portion in the back of the brain is the occipital lobe, and that is supplied by the posterior cerebral artery. And your occipital lobe is what coordinates your vision. So when you have damage to the PCA from a stroke, you lose vision, and I'm circling that here on the bottom to remind you of that. Vision is what's associated with PCA strokes. We'll talk more about that in a minute. For MCA and ACA strokes, let's look over here at this drawing on the right. The red area is what's supplied by the middle cerebral artery. It's a large territory of the lateral portion of the brain. The anterior cerebral artery supplies this thin strip at the top, and then it supplies everything that's over the edge that you can't see on the medial side of the brain. So to understand the difference between MCA and ACA strokes, you have to understand the homunculus, which is what I've drawn right here. So if you took the motor strip out of the frontal lobe and turned it on its side, this would be the lateral portion of the brain here, and this would be the medial portion of the brain here. The nerves that supply the arm and the face are on the lateral portion of that motor strip. The nerves that supply the leg and trunk are on the medial portion of that strip right there. And we call this the homunculus. It's the distribution of nerve fibers in the motor strip of the brain. The most important thing to know about the homunculus is that the MCA mostly supplies this portion out here, where the arm and face are, and the ACA mostly supplies this portion in here, where the trunk and legs are. So ACA strokes give you more lower extremity symptoms, and MCA strokes give you more hand and face symptoms, and we'll talk about that in a minute. So let's take a look at this axial section of the brain, and I'm going to show you the different vascular territories from the different arteries. First of all, notice that I've drawn some of the key subcortical structures like the thalamus, the internal capsule, and then portions of the basal ganglia up here like the caudate putamen and globus pallidus. So I'm going to start by using a blue highlighter, and I'm going to first identify the areas of this cross-section perfused by the posterior cerebral artery. So remember, the PCA does everything in the back of the brain in the occipital lobe, so all this territory down here that I'm highlighting in blue is perfused by the posterior cerebral artery. Now also, there are some deep branches of the PCA which perfuse the thalamus right here, and we'll talk about this later, but strokes of branches of the PCA can give you damage to the thalamus. So now I'm going to switch to green and show you the areas that are supplied by the ACA. So that's everything up here in the front. And there are also deep branches of the ACA that get some of these subcortical structures here, like the caudate. And then finally, I'll use a red highlighter here to show you everything supplied by the MCA. It supplies this very large territory of the cortex out in the lateral part of the brain. And then there are deep branches of the MCA which get these structures down here, like the internal capsule and the globus pallidus and some of the basal ganglia structures. Those can all be damaged by deep branch strokes of the MCA. And then finally, there's this little strip right here that's supplied by a vessel called the anterior choroidal artery, which kind of comes off the internal carotid and MCA right where they branch, and that gets this posterior limb of the internal capsule right here. So now let's talk about the specific subtypes of cerebral stroke. So we'll start with an MCA stroke, and this is how it would present. A 75-year-old man with recent onset loss of movement of his right arm. The right side of his face also droops, and there is drooling from the corner of his mouth on the right side. He also has difficulty speaking. So you should know that this man is having an MCA stroke, and that's the most common site of a stroke. You should also know that MCA strokes give you contralateral motor and sensory symptoms. So if you infarct the left MCA territory, you get symptoms on the right side of the body. The arm is affected more than the leg, and that's because of that distribution of nerves in the homunculus that we saw before. And then the face is affected because the face is also on the homunculus in the MCA territory. These patients have upper motor neuron symptoms, so those are spastic paralysis type symptoms. And then if the MCA stroke is on the left side of the brain, it affects the speech area, so patients will develop aphasia. If it's on the right side of the brain, patients get symptoms of hemineglect, and this is where they cannot recognize objects that are presented to them visually. Our patient had a lower facial droop, so why did he have that? Well, let's review the facial motor nucleus in the pons over here. So it separately supplies nerves to the lower portion of the face and the upper portion, or forehead. And you need to know that the upper portion has dual innervation from both sides of the cortex, so both the left side over here and the right side over here supply the upper portion of the forehead. So if you lose just one side, there will still be innervation from the opposite cortex. The lower portion of the face, however, is only supplied with upper motor neurons from one half of the cortex. So damage to one half of the cortex will cause you to get a spastic upper motor neuron paralysis of the lower face only. So this slide is just a summary of some of those things I said to make sure this is clear, because this is an important point. The upper face has a dual upper motor neuron supply. The lower face has a single upper motor neuron supply from the contralateral motor cortex with fibers running in the corticobulbar tract. So MCA stroke damages the upper motor neurons. The upper face remains intact from that dual blood supply, but the lower face will have spastic paralysis. And this is what a CAT scan of the head might look like in a patient with an MCA stroke. And you can see that there's a large territory of dark brain tissue in the medial portion of the lobe that's been affected by the MCA stroke. Now let's talk about an anterior cerebral artery stroke. So this is a 75-year-old man who has the acute loss of ability to move his right hip and leg. On exam, he has decreased sensation to pinprick and vibration of his right leg. So this man is having a left anterior cerebral artery, or ACA territory stroke. You know it's the left because the symptoms are on the right side of the body. And strokes in the ACA territory tend to affect the legs more than the arms. This is the second most common stroke site after the MCA territory. ACA strokes affect the medial portion of the cortex, the midline portion of the homunculus. If we look at this drawing of the homunculus on the screen, it's this portion near the midline that is affected in ACA strokes, and that portion relates to the leg-foot area. And for that reason, patients who have ACA territory strokes have motor and sensory problems related to the legs and the feet more than related to the arms. Now let's talk about a PCA stroke. This is an 80-year-old man who presents with acute visual loss. He has difficulty seeing objects on his right side. His wife said he also reports seeing people who are not in the room. On exam, there are no motor or sensory deficits. Visual fields are shown below, and the black means there's no vision. So this is a PCA stroke, and that affects the posterior portion of the brain, which includes the visual cortex. One of the symptoms patients can have are visual hallucinations, just like the patient we described was seeing people who weren't in the room. They also can have visual agnosia, where they see things but can't recognize them. And the classic visual field deficit is contralateral hemianopia with macular sparing, and let's talk about what that means. So on the module about neurological eye disorders, I talk about different visual field defects, and I won't revisit all of that now. But what I will tell you is the left portion of both visual fields, which I've drawn in blue here in this picture on the left, all gets processed over to the right side of the body here and processed by the right posterior lobe. So if you damage the right posterior lobe, or if you damage the right optic tract back here, you will lose the left side of both visual fields. And I've drawn some of those visual field examples over here on the right side of the screen. So a left PCA stroke or a left optic tract lesion gives you right visual loss, like what I've shown up here. Conversely, a right PCA stroke or a right optic tract lesion gives you left visual field loss. So our patient had macular sparing. So what does that mean? Well, the macula is the central high-resolution portion of our visual fields. It's what we use to read. And it has a dual blood supply from the MCA and PCA. So therefore, PCA strokes often spare the macula. So what you get are the visual fields I've shown below. you lose one half of both sides of the eye because of damage to the occipital lobe in the back of the brain, but you spare that little circle in the middle of the eye which represents the macular area. Deep branches of the PCA supply the thalamus, so you can get something called a thalamic syndrome if you have ischemia of those deep branches. And this will give you contralateral sensory loss of the face, arms, and legs. Remember, all the sensation of the body except for smell funnels through the thalamus, so you will lose all the sensation in the body if there's damage to the thalamus. You also get a proprioception defect, so these patients will present with loss of balance and falls. But then importantly, there will be no motor deficits because all you've lost is the sensory information that goes through the thalamus. When this syndrome resolves, some patients are left with a chronic pain condition on the contralateral side of their body, where it's very painful to be touched at all on that side of the body, and that's called a thalamic syndrome. Now we're going to talk about something called hypoxic encephalopathy, and this is what happens when you lose blood flow to the central nervous system. It only takes about 10 seconds of loss of blood flow to cause unconsciousness, and then you get permanent damage within 4 minutes, and that's because neurons have no glycogen storage, so they're very susceptible to ischemia. Usually when you get global ischemia to the brain, patients end up in a coma, and they often end up in a vegetative state. And this can be caused by things like shock, so a patient who has a massive heart attack and their heart doesn't pump for a long period of time can get hypoxic encephalopathy. If you have severe anemia, it can also occur. And then if you're repeatedly hypoglycemic, like happens to some diabetics, this can also cause hypoxic encephalopathy. It's high yield to know the two types of cells that are highly vulnerable to hypoxic damage. One type of cell is in the hippocampus. These are pyramidal cells. And then also in the cerebellum, there are cells called Purkinje cells, and these are both highly vulnerable to damage if they lose blood flow. The areas of the cortex that are most vulnerable to decreased blood flow are the distal branches of the major arteries, and this is called a watershed infarct. So if you have decreased blood flow to the brain, you get ischemia in the border zones between the MCA and the ACA and PCA. And I'm going to draw that for you down here in this axial section. So right here we have the border zone between the MCA and the ACA, and back here we have the border zone between the PCA and the MCA, and because these are border zones, they're supplied by very distal vessels, and they're the most vulnerable to ischemia. And the classic scenario for this to occur is someone who's had a big myocardial infarction and then afterwards has central nervous system damage. The areas at which that damage is most likely to occur are the areas I've highlighted on this picture. As I said before, most patients who have global ischemia to the brain go into a coma and often develop persistent vegetative state. But if they survive, they can have this characteristic motor loss pattern where they have weakness of the shoulders and thighs, but sparing of the face, hands, and feet. And these are bilateral symptoms because it's global ischemia. And this is sometimes described as a man in a barrel syndrome because it's as if they've got a barrel around them. They can move their hands and feet, but they can't move their thighs and shoulders. So the last thing we're going to discuss in this module is the lacunar strokes. And the thing you need to know about lacunar strokes is that they affect a very small area of the brain and that they're associated with poorly controlled hypertension. These are small strokes that resolve and leave behind a lacuna in the brain. And a lacuna is a Latin word for empty space. So there's a tiny empty space left behind in the brain after the stroke. These strokes affect such a small anatomical area that they often don't show on the initial CAT scan. And in addition to hypertension, they're also associated with diabetes and smoking. Lacunar strokes are very different from the big cortical infarcts we talked about in terms of the ACA, the MCA, and PCA. In fact, lacunar strokes are called non-cortical infarcts because they lacked what are known as cortical signs. So things like aphasia and agnosia and hemianopsia, we saw these when there was major damage to one of the lobes of the brain, but you don't see those things in lacunar strokes because they affect a much smaller area of the brain. Lacunar strokes commonly cause hemiparesis, and that's because they damage the internal capsule. So if you look over here at this cross-section of the brain on the right, I'm drawing a line through the internal capsule. And damage to this area causes motor loss in the lower extremity in both the arms and the legs. And this is different from the MCA or ACA strokes where they tended to affect one area, legs or arms, more than the other. When you damage the internal capsule, you usually lose both limbs. You can also get damage to the thalamus, and over here on the right I'm drawing some blue lines through the thalamus, and this will cause sensory loss to the arm, legs, and face. You can get damage to the basal ganglia, and over here on the right I'm drawing some lines through the putamen and globus pallidus. Up here is the caudate, and then you can also get damage to the pons. There are many blood vessels which can give rise to lacunar strokes, but one of the most common are the lenticulostriate arteries, which are deep branches of the MCA artery. And they supply this area that I'm highlighting with my red marker over here on the right. And that's where the damage often happens in lacunar strokes. So on this slide I've listed some of the vessels that often give rise to lacunar strokes, and one of the most common is the lenticulostriate branches of the middle cerebral artery. And this is the vessel that supplies the internal capsule and the basal ganglia like I just showed you in the last slide. Also the anterior choroidal artery, which arises off the carotid, right where it branches with the MCA, sometimes gives rise to lacunar strokes. And then these last three are less common, but they've also been implicated: the recurrent artery of Hübner, the thalamoperforate branch of the PCA, and the paramedian branches of the basilar artery. People have tried to look at the pathophysiology of lacunar strokes because this is a very strange phenomenon to find these small holes in the brain. One thing we know for sure is that underlying all lacunar strokes is arteriolar sclerosis from hypertension. So in the videos on hypertension in the cardiology section, I talk about arteriosclerosis, that is hardening of the arteries. In this case, you have hardening of the arterioles, the small blood vessels, and that's seen in all cases of lacunar strokes, and it's caused by hypertension. Beyond this, what leads to the lacunar strokes is not well understood, but there are two major proposed mechanisms. The first is called lipohyalinosis. This is small vessel narrowing from hyaline deposition, similar to hyaline arteriosclerosis that you can see from hypertension. The other proposed cause is microatheroma. These are similar to the atheroma you see in large vessels like the coronary arteries. They involve plaque with macrophages in the vessel wall, but in this case, instead of talking about a large vessel like a coronary artery, we are talking about small vessels in the brain. So in the 1960s, a man named Charles Fisher did careful autopsy studies of patients with lacunar strokes, and he correlated the location of the lacunae to the symptoms they had before the stroke. And based on his work, there are 5 subtypes of lacunar strokes that have been identified. The first subtype is the most common, and that's the pure motor stroke. These patients have a lacunar infarct with paralysis of the face, arm, and leg on one side of the body. And this happens when there's damage to the internal capsule because all those motor fibers run through the internal capsule. The second subtype of lacunar stroke is the pure sensory stroke. So these patients had numbness and sensory loss on one side of the body in the face, arms, and legs. And this occurred when there was damage to the VPL portion of the thalamus. And that should make sense to you because all the sensory information in the body funnels through the VPL section of the thalamus. The next type is called sensory motor, and that's a mix of the other two. These patients have paralysis and sensory loss, and they have damage to the thalamus, the internal capsule, and also evidence of damage to some of the basal ganglia like the caudate and putamen, and also the pons. The last two types are rare and are very different from the other three. So ataxic hemiparesis occurs when patients have weakness, that's the hemiparesis part, and then they have dysarthria, which is difficulty speaking. Now you may associate difficulty speaking with problems to the left side of the brain, and that's true, but you can also get it when you have cerebellar dysfunction. You need your cerebellum to coordinate your muscles in order to speak properly, and patients with ataxia can have dysarthria and difficulty speaking. And one characteristic of ataxic hemiparesis is that the ataxia is much, much worse than the weakness. So the weakness may be relatively mild, but the ataxia is severe. And these patients have lacunar infarcts in the base of the pons and the internal capsule. And then the last type is dysarthria or clumsy hand syndrome. So these patients, as the name implies, have difficulty speaking, that same dysarthria we just talked about, and they also have clumsiness or weakness of the hand. And these patients had lacunae in the pons and the internal capsule. There's a movement disorder called hemiballism, where patients have wild, flinging movements of their extremities on one half of their body. You may know the term ballistic, as in to go ballistic, which means to thrash around wildly. These patients are hemiballistic, so half of their body is moving wildly. And this happens when there's damage to the subthalamic nucleus, and it's seen in rare subtypes of lacunar strokes. This is not one of the 5 subtypes that Fisher identified in the 1960s, but you can see this. And the boards like to ask you about this because it involves damage to a specific portion of the basal ganglia, and that's the subthalamic nucleus. So the classic lacunar stroke patient is going to be a patient with uncontrolled hypertension, and they're going to present with symptoms consistent with one of the 5 lacunar subtypes. So most likely this will be pure motor because that's the most common type. These patients will have leg and arm dysfunction that's equal, and this is from damage to the internal capsule. You may also see the pure sensory subtype where there's damage to the thalamus. The other subtypes are all much more rare. And then importantly, they'll often tell you in board questions that there's a negative initial head CT, and this should be a tip-off that it may be a lacunar stroke syndrome. And that concludes our module on cerebral and lacunar strokes.